Good afternoon. This is Dr. John Bennett broadcasting from Miami. We have here today the honor of having John Byler, the traumatic brain injury patient supporter and writer. He wrote a book called You Look Great on Amazon about the journey of someone recovering from traumatic brain injury. And we're also joined by Shannon. Let's say hi to Shannon first. Hi, Shannon.
Hello.
How you doing? And you're a traumatic brain injury supporter who we just interviewed, correct?
Yes, sir.
Okay, we'll see that on YouTube. Okay, John, welcome back.
Thank you, John. It's a privilege to be here. I'm surrounded by some wonderful credentialed neurosurgeons, and it's an honor to be here, especially representing my slice of it, which is the survivor. I didn't have to go through neurosurgery. I do have a presentation, and should I just go ahead and go on to
Sure.
my presentation now? Okay.
Okay. Do you want to talk a little bit about who you are, where you are, or is that in the presentation?
It's actually in the presentation.
Okay, that's fine.
So
that's fine.
yeah. So what you see here is a picture of my book. You Look Great. It's strategies for living inside a brain injury. It's not a memoir. It's really the best of what I learned at Spaulding Rehabilitation Hospital in Boston, which is a Harvard Medical School teaching hospital. And the picture I chose was a friend of mine sent this to me, and it's something every author wants to see, is a well-marked, well-used copy of the book. Mm-hmm. So just to start it off, a piece of brain tissue the size of a grain of sand contains 100,000 neurons and 1 billion synapses, all talking to one another. As far as I'm concerned, NASA can have Mars, because neurotrauma rehabilitation is the next great frontier. Here's a sample of statistics, and
okay, John, I'm sorry to interrupt, John. You're still on the first slide.
I'm on the first slide?
Yeah. Sometimes we have a little problem with the see if you can move. You got to kind of click on the slide with your mouse.
Okay.
Okay.
So
I don't know if you remember there you go. Okay. Okay, there we go.
I'm gonna not go full screen then, if that's okay. I'll just do it like this.
That's fine.
Okay. I think that's where the problem was. Okay, so NASA can have Mars because neurotrauma rehab is the next great frontier. Okay, so are we tracking that?
Yes.
Okay, so this is just some statistics that I've grouped together, the brain-oriented ones, and as you see, a lot needs to be done with restoring brain health. And here's another way of looking at it. Traumatic brain injuries account for about 1.5 million. So Hippocrates, the father of medicine, some say, men ought to know that from nothing else but the brain come joys, delights, laughter and sports, grief, despondency, and lamentation. And you'd think we'd take better care of it. I'll just touch on the subject of football before I get into the rest of it. This neurologist tested the brains of 79 ex-NFL players believed to have brain damage. She found it in 76 of them. This I saw in a grocery store, and I was appalled, frankly, because we have to help our children choose their heroes. And this cage fighting takes boxing to another, more barbaric level. And I just want us to be aware that the brain health is all around us, and opportunities to stand for brain health. This was a cartoon I would share. I won't lie, it doesn't look good. And there's the Grim Reaper at the other end of the ring. As far as my story goes, I was in a car accident about 10.5 years ago, hit from behind. My middle son, Andrew, was with me. He broke 3 vertebrae in his back and still lives with pain. And I am still recovering from my traumatic brain injury. But I did have very good help, as I said. Spaulding, the Harvard connection. And then before I finished my book, about a year before, I finished it at the end of 2011, but I had been asked to be on the board of the Brain Injury Association of Massachusetts, so that there was a voice of the injured on the board, and that's been a wonderful experience for me. My doctor, Ross Safant, when I first met with him, he said, "Mr. Byler, don't think that I can, heal you, but well, let's shoot for this. Let's aim for a 25% improvement in the quality of your life." And so I signed up for that because my life was extremely miserable at the time. So I'm going to go over the objectives, and the presentation itself is divided into 3 parts: awareness, adjustment, and acceptance. And those are the 3 categories of my book as well. My objectives are simply to describe what I'm calling the brain injury recovery team model, which is an interdisciplinary approach to neurotrauma rehabilitation involving the medical team and a therapy team. And as Dr. Zafant had me agree with him, I believe that if the model is followed, it would improve the quality of your life, your recovery by 25%. Here's a statement of the problem. If the patient doesn't have a great vocabulary, basically the patient is saying, "I should feel terrible." And any attempts to treat the patient are often blinkered and random. And to save time, the doctor often leads the witness. Are you depressed? Are you feeling anxious? And what I point out in the book is that there's a big difference between clinical depression and sadness, between clinical anxiety and nervousness, and out come the pills. And at a minimum, the model will help create a checklist before resorting to pharmaceutical solutions, because they can be a slippery slope and very hard to get your brain back to the chemistry that it was born with and it is used to. And it has been a very difficult time for me. Going on and off various medications. If you give 5 neurologists the sequelae of your TBI, and I use the word sequelae, my understanding is after a few days, if these symptoms persist, they no longer call them symptoms, they're called sequelae. I never questioned that. So, but my point is, if you give 5 neurologists the sequelae, you'll likely get 5 different diagnoses. My friend David on the left here, he was a library science person when he got his injury in a library of all places. He was sitting down under near a file cabinet, and somebody had opened the top drawer, and he stood up very quickly, and he sustained his injury in a library. So David compared the current state of research into mild TBI with AIDS research in the early 1980s. They knew there was a problem. What do we do about it? And I believe the real cutting-edge research on mild TBI is not trickling down to or bubbling up to even the major hospitals. So here's my attempt at a solution. Before my injury, I was an instructional designer. And in the first year of my recovery, I couldn't talk very clearly at all. I cried a lot, and I was depressed and slept a lot. And so but the instructional designer in me paid attention to what Spaulding was doing with me. And so I created this model, which I'll explain. It systematizes options that doctors often leave unexplored. It helps them make referral decisions deliberately. And it gives patients and caregivers a better understanding, a roadmap of what lies ahead in their recovery process. So that's where we're headed. Are there any questions before I launch into awareness? Okay, I'll just plow on.
All right, we're all set, Sean.
What's that?
No questions so far.
Okay. So awareness. My eldest son is a filmmaker, and if you go on YouTube and type in "You Look Great" and my name Byler, you'll see some of the short films that he's done. But whether survivors are watching the film or reading my book, what I hear from them is that I'm not alone, I'm not crazy, I'm not lazy, and I need a proper diagnosis. This is what life often feels like. We think of the gentle sands of time floating down upon our heads, but with a brain injury, life is much more difficult than that. This is also sometimes what it feels like. And you'll see that the death doors over on the right, and so when your life is spinning out of control, you do think about death a lot. And our veterans, I finished the book, I thought, in the middle of 2011, but then I saw the statistic that the suicide rate among veterans had exceeded the combat deaths. And I doubled my efforts, and for the next 5 months, I beefed up the sections on clinical depression, on suicide, on living this new life. Let's step back. Why is treating TBI, especially so-called mild TBI, so hard? Again, David says people can sustain a mild TBI and have traumatic outcomes. It's often called an invisible injury. Oftentimes, the damage is at the neuron level and won't show up on an MRI. And so even practiced doctors and neurologists will look at their patient and say, we can't find anything wrong with you because it doesn't show up on the MRIs. I believe that the technology is they're working on that to actually show a scan that will show that level of damage. So here's the sorts of things that are a challenge: managing pain, sustaining a conversation, reading, shopping, organizing things, following a recipe, even an evening with friends can be, even if you're laughing, the next day you feel as though you're paying for it. Here's what one way of helping loved ones and caregivers understand your particular fingerprint of an injury is to take at Spalding they had a brochure that categorized the sequelae in 4 areas: medical, sensory motor, intellectual, cognitive, and social personality. So I underlined the ones that applied to me, and that's very helpful because there is a fair amount of overlap. Even though the source of the injury is wildly different. Car accident, yes, but also a football field, veterans, there's any number of ways of sustaining a brain injury. How is your pain today? This is just from one thing that but survivors will tell you is that humor really helps. You know, you go to any support group meeting, and if somebody says something even mildly funny, people will just feel the release and laugh and say, you know what, life doesn't have to always be so grim. For me, I found help. Maybe each of us have our own unique senses of humor, but these were things that helped me. It does release a wonderful chemical. And it's free, it's legal, and healing. But no matter where we go, we do drag the injury around wherever we go. We have a cabin up in Maine that I spent some time in whilst I was writing the book, but I was looking out at this paradise, lake, trees, quiet, and I knew that I had dragged my injury there with me. Another sensation is the claustrophobia, because, for example, if you're in an MRI, you know that nurse is going to pull you out in about a half an hour. You don't have that confidence with the brain injury. There's no one going to come take us out of this. So we have to focus, and we have to stay strong and disciplined, and do what we can to know that we can somehow overcome the intense feelings of claustrophobia. Defensive. Why would you be defensive? Well, the worst thing you can do to a person with an invisible illness is to make them feel like they need to prove how sick they are. This gentleman on the picture, he's actually a jewel forger or something, but he looked like an arrogant man who knew all the answers, and some doctors come across that way. I heard these things from various people. I don't know why you're not getting better. And frankly, I'm discouraged at your progress. Most people would be better by now. And of course, your MRI is fine. And your friends can say the darndest things. A friend told me my son had 8 concussions. Did you have a relaxing day today, Mr. Byler? Which was a nice thing to say, but I had had a horrible day. And I was sitting there reading the paper, and it looked like I had the day off. And then, of course, put it behind you, move on. And you think they're thinking, what brain injury? And why can't you go back to work? There's an incredible, a powerful sense of loneliness that sets in. A friend of mine from Charlestown, Massachusetts, I quote him the most in my book. In my book, he's named Mike because he was going through some legal things at the time. But he told me, nobody on the face of the earth, no doctor, therapist, or rehab person, knows what it's like to be affected by TBI. They know only what their patients report and what their textbooks say. Loneliness? It's so lonely. There should be another word for it. How do you mourn the loss of yourself? Eye contact, $1. Matt told me, he said, I haven't made eye contact with anyone in 6 months. And that's when he decided to get a dog. And his dog is his best friend now. This is Matt on his wedding day. And this is Matt last year. A friend of mine, Elizabeth, from New York City, just offered some illustrations for my book. This one came out after the book came out, but this is her take on depression. And this is in the book. You see here just a woman who is lost. There's an eye, perhaps representing hope, and she's holding on to a pendant of love. Loss of self. So the awareness section was when it's starting to really set in that you're changed and you don't know what to do next. Adjustment is all about the focus will be on the brain injury recovery team model. I think I'll take a quick drink of water. Are there any questions about the awareness?
John, I just want to introduce a couple of Dr. Victor Hugo Perez from Mexico City. He did a presentation today on an impromptu on neuroanatomy. Excellent presentation. Victor, this is John Byler. He's the author of a book on traumatic brain injury from the patient's viewpoint. And also this is Shannon to your right. And we have also another arrival. Hello, could you introduce yourself, please?
Hello, I'm Helen. I'm a retired nurse of 40 years with the concept, pretty much it seems like the whole world is stressed out that we're all brain injured. Oh. And I am just trying to figure out how to build a new paradigm, which Shannon knows I call the woman. I'm one of the 8 pilot projects in the Global New Man, which is a mutual aid network. Okay. And I'm advocating for the development of the wellness-oriented mutual aid network where we can use technology to be supportive of each other and develop the checklists for health and wellness to be local to global, helping individuals, families, work sites, really a whole new paradigm. The things that aren't covered by insurance, like John said, humor is not covered, all of those kinds of things. Play therapy is not covered.
Okay, very good. Welcome. And Victor, could you introduce yourself, please?
Yeah, hi, nice to meet you. I'm from Mexico City. I am a brain surgeon, and also I did a skull-based surgery research fellowship about 23 years ago in Detroit, Michigan, and I am really happy to see you, to know you, and to participate in this interesting course. Nice to meet you.
Oh, great. Thank you, Doctor.
Yeah, this is okay, John.
Okay, I'm going to plow on then. Welcome, everybody. Adjustment. To have and have not. Seen as a whole person, a TBI patient's condition and course of treatment must account for the interdisciplinary nature of a brain injury. Rehabilitation interventions have as much to do with recovery as medical ones. And here's the model at a glance, and I'll walk us through each briefly. Again, it serves as a checklist. Before jumping to the pharmaceutical solution, I urge every survivor to have these areas checked first. Endocrinologist, when doctors saw my MRI, they did not see any damage. But when I went to see an endocrinologist, he put the same MRI up on a light box, and he went right to the pituitary gland. He said, I don't like the looks of that. I went back for a 45-minute MRI, and he saw that the pituitary gland was empty, and I needed to do something about that. It was due to the car accident. A neuropsychiatrist, as we said, the invisible injury, therefore we need to find ways to quantify the injury. And this is a great way of beginning to quantify where your deficits are. This is often a 6 to 8 hour marathon that you have to spread out over 3 days. Don't try and do it all in one day. And just as an MRI takes pictures from so many angles of your brain, so does a neuropsych test. It will test spatial reasoning, logic, vocabulary, what shape comes next, all kinds of things. I urge you to get a neuropsych exam done. I'm sorry, that's the neuropsychologist. The neuropsychiatrist is distinguished from a psychiatrist because it pays special attention to the damaged brain. The neurooptometrist, my understanding is there are only about 400 of them in the United States, far different from an optometrist. The neurooptometrist has a thorough background and training in how brain damage can affect the optical nerves, and many people do experience differences in vision after their injury. A psychopharmacologist, that kind of speaks for itself. A sleep study, that's one of the more obvious reasons you feel so terrible. Make sure that you get that sleep study done. They might decide you're not getting any REM, which is when the brain heals itself, and they might decide you need a CPAP. That's a relatively straightforward fix, and that will at least help you feel less miserable. Vestibular testing. One of the case studies in my book is of a fireman who, the irony of his injury is he can't get on a ladder anymore because his balance is off. Now that's an area where he and I don't have an overlap. I don't have vestibular problems, but this is my first take at the medical list. Get these things checked out. The medications. This book, I don't read much anymore, but I couldn't put this book down. Dr. Carlott, you can find him on LinkedIn. He has a private practice in Newburyport, Massachusetts, my old home state. He's very, very forthcoming about the conflict of interest between the prescribing doctor and various perks from pharmaceutical reps and the danger and the traps of that, and how talk therapy is becoming a lost art and science. If you're a business person and you have a private practice, it won't take long to decide that you could see 4 patients in an hour if you're just prescribing and say, come and see me in a month or 3 months and tell me how it's going, instead of spending 1 hour with one patient and try to get to the root of other reasons why they might feel so terrible. Maybe their marriage is falling apart. In this cartoon, you know that the race car drivers, they have their sponsors. Well, this is kind of what it feels like from a patient's point of view. You see it all over the place. You see it on their stationery, just about on their jacket. So you got to be careful about that. Discouraging data on the antidepressant. Actually, the New Yorker got some flack about the hanging rat, but it does make the point. In my own case, and in the case of some of my friends and colleagues, we weren't feeling suicidal until we started taking the antidepressants to take care of our sadness. This is how our brains feel, like pickles and brine, and we don't know what to do. The person who takes medicine must recover twice, once from the disease and once from the medicine. So that's the medical side. And I'm going to get into I'm not going to define these very, very well. I think they're so obvious, but and again, some patients will need some of these helps and others won't. Occupational therapist, a physical therapist. I didn't need physical therapy. I wasn't paralyzed, or I didn't need to learn to walk again. The social worker, yeah, I needed a social worker. My social interactions were much different now. I had to, if I went to a gathering, I had to go upstairs in a dark room for a couple hours. It just wasn't working out. My speech language pathologist on the upper right-hand corner, that's Rick Sanders. He was my most valuable player. He helped me put my speech back together again, and I'm grateful. And he invited me to come speak to his graduate school classes, and that's really the genesis of the book. I had a presentation, and I had ample time for Q&A, and I really got at what the grad students really wanted to learn more about. And then there's the vocational rehabilitation counselor. What I would say is to make the most of your appointments, survivors look to clinicians. And these are 3 categories that I go into little detail in my book, but I'll just give you the categories. Emotional support, informed guidance, and tactical support. Tactical support might be something like, your employer needs a note or something. So watch for signs of clinical depression and suicide. And then these are things that I've heard a number of times. I'm telling you, John, if I had a gun, I'd shoot myself. I said, you know what, you've told me that 4 times now. He didn't even realize he had told me that 4 times. And other things you hear quite a bit. I just want to disappear. I've said that too. Now, each of these 6 highlights of my strategy sessions with my team, each one of these could serve as a topic for discussion at any support group meeting. Okay, I go into a little explanation of what each one is in the book, but for now I'll just give you the highlights. Pace yourself. And every survivor knows what I'm talking about. You exert yourself even for 20 minutes, and you're like, I got to go lay down. Number 2, count the cost of every activity. Now, going to your son's baseball game or something, that's an awful good use of your time. You'll pay for it, but choose your activity. Number 3, don't be hard on yourself. I made a wrong turn a couple weeks ago, and I was hard on myself. And it struck me about 10 minutes later, saying, if a friend of yours was driving, you wouldn't have criticized him or her. Just take it easy on yourself. You made a mistake, so what? Number 4, write things down. Write things down. You won't remember them. Number 5, avoid isolation. Orchestrate lunches. Orchestrate meetings with people that maybe one person. Number 6, be hopeful. The number 1 cause of suicide? Hopelessness. A sense of hopelessness. Be hopeful. Please, handle with care. We are fragile. And again, as we drag our injury, we need to learn to travel lightly. We need to figure out what is our critical path today. What can be left till tomorrow? No problem. And if you're a driven person, a type A personality, an achiever, a brain injury can be very difficult because you expect and demand a lot out of yourself, and it's going to mean saying no to some things, and I'm still learning that, to say no. I will say a word about support groups. When I first went, within a year, well, I'll read it. They should come with a warning, like on a pack of cigarettes. I visited one less than a year after the accident. I said never again. It was so depressing. 2 guys were 8 years into their injury and in the middle of painful divorces. I wasn't strong enough to be the strong one in those interactions. I needed support. I couldn't resist this one. It's always poor you, isn't it, Albert? The fraternity of the injured is strong. We talk in shorthand to each other. We feel less alone, less isolated. We laugh when we say, you get it, you understand. My friend Don, I don't believe Don is living anymore. He was suffering from herpes encephalitis. That's different from a car accident. But he saw so much commonality in our injuries that he high-fived me 4 times over lunch because he felt I understood him. And we shared our strategies with each other. So that's the brain injury recovery team model at a glance. And you'll see it there. Again, the interdisciplinary approach, they ensure, these checklists ensure an efficiency and an efficacy in building a recovery team. Now, one of my missions is to create a school, 2 sets of professionals in one school. Effective brain injury recovery depends on highly and specifically trained medical and rehabilitation professionals. Just as recovery takes place in one person, training and education for recovery should take place in one school. Now, I ran across this picture, and I thought, well, it probably won't look like this, but it's cool that it has an X in it, which accounts for the model. So the School for Brain Injury Recovery. And one thing I do want to tell clinicians of all stripes, that you tip your hand when you're with your patient. You tip your hand on where your intentions lie. Are you a kind person? Are you a judgmental person? Are you a severe person? And this rabbi says to be kind is more important than to be right. Many times what people need is not a brilliant mind that speaks, but a special heart that listens. And I posted this on LinkedIn. I'll just read it because it says it's so true. Those of us with, quote, special needs meet with so many specialists. in my case, members of the brain injury recovery team, as described in my book. And the men and women who begin with kindness tip their hand on their honest intentions. Purely cerebral approaches are shallow, brittle. A warm human spirit breathes more life into us than a well-credentialed expert in the field. So those were the objectives. We went over the model, and I believe if followed before the pharmaceutical solution, it could improve the quality of your life or recovery. I am working on a sequel. It's a play on the word neuroplasticity. That's one of my favorite words, neuroplasticity. For me, that's a sign of hope that our brains can be restored. And so my sequel is called Neuroplastic Cities, looking beyond hospitals and medical schools for neurotherapy. Even a place like Spalding, after a few years, there's not much they can do with the walking wounded. You start being denied access to members of your team, and you're really on your own, and you find that you're learning a lot at support group meetings. Here's a new slide, John, and it kind of ties together what I'm trying to get at. Your brain injury, and I'm addressing my audience, the brain injury audience, your brain injury is as specific as your fingerprint, and so should your course of treatments be. Try them all. You owe it to yourself to create the multi-tooth key to your recovery. Again, a checklist. So I'm going to walk through a few therapies. Some I've tried, some I haven't. But I'm of the belief that you should try them, because some will work for some and some won't work for others, and if you try them all, you'll find the combination that works for you. For example, hyperbaric oxygen chamber treatments. I've heard nothing but good things about this. I've never had one. I don't qualify. I don't have glaucoma. So the more enlightened rehab centers will start offering these treatments. It'll all be figured into the cost, and we have to get Medicare to recognize it too. There are certain light boxes that emit certain lights that some people have had very good success with. I have experienced cranial sacral therapy. You know, if you can enrich somebody's life that day and say that feels good, that feels better, they're going to be less likely to want to take their life. So cranial sacral therapy is it starts with a massage on your scalp, and there's so many nerve endings on your scalp. I think people don't realize that. And even if you don't have a professional, have a loved one. Just give your scalp a nice massage for about 20 minutes. Back to Hippocrates, the father of medicine. Our food should be our medicine, and our medicine should be our food. That's what I believe. And here's just one of many number of articles out there. It's easy to Google brain health and nutrition, and the two words that jump out at me are neuroprotective and neurorestorative. And there are foods like blueberries that have these qualities, and so change your diet and pay attention to your brain's health, and don't eat junk, and drink a lot of fresh water. Nutritional supplements, absolutely. I don't know if you've heard of chlorella or spirulina, but these things are deep, rich, green supplements, far more nutrition than even iceberg lettuce. Fish and krill oil, probiotics, 5-HTP. My doctor has gotten me off of my pharmaceuticals, and he's very strict. I'm supposed to limit sugar, gluten, dairy even. No dairy for me. So I drink cashew milk instead. And he sent me an article that a handful of cashews will have the same effect as Zoloft or another similar antidepressant. So that's good enough for me. And now I do enjoy a glass of wine occasionally, so I'm not real strict about that. But it has been described to me as a neurotoxin. And walk, don't run, because running kind of jiggles your brain around. I mean, you can. I think it might be an individual thing. It doesn't help me. I walk instead of running. Music is big. The listening to it, the performing of it. I'm a guitar player, and specifically I play blues. And my music has improved because I play, I guess, more sincerely, more deeply. I pay attention to the notes more than I did before the injury. I would encourage everyone to pursue music in some way. Marijuana is getting a lot of attention. Even somebody as mainstream as Sanjay Gupta says it's irresponsible to not provide the best care we can, care that often may involve marijuana. Now here's some sample journal articles. These were in my book, which came out 4.5 years ago, so you can see the kind of work that's being done now. Endocannabinoids and traumatic brain injury. I mean, I won't bother reading them all, but if results bear out this grassroots anecdotal evidence, perhaps state laws on medical marijuana should be mellowed. It's certainly helping a number of veterans who are struggling with PTSD. You know, I heard on the radio, John, a couple weeks ago, I was on my way into Wichita, and there was somebody on NPR who called PTSD an untreatable condition. I recoiled. It's not untreatable. There are a number of things you can do for PTSD, even though it is severe trauma. Now, it did affect when I was on this medicine a couple of years ago, I lived in Colorado just to experiment with some things, and it did affect me in some ways, and some people thought that I had become an entirely new person. Asian therapies. Some people are reluctant to try a therapy that they can't pronounce, and so I would say we need to get over that and learn to pronounce things that have helped people for thousands of years. You know, Qigong has helped me. I haven't learned Tai Chi yet, but I grew up in Hong Kong as a missionary kid. And so from 62 to 68, I grew up in this city where I saw large groups of men and women of all ages performing Tai Chi together. It was beautiful, it was rhythmic, it was well balanced, and I'm looking forward to taking some lessons on that. Acupuncture, I took that for a while, and I couldn't really tell if it was a placebo, and every once in a while that needle did hit a nerve, and I found it kind of an unpleasant experience. So I'm not eager to go back to acupuncture, but it does help many, many people. Reiki, that has helped me. Reflexology is focused on the foot, and I've had 2 treatments done, both of them on the Isle of Wight, actually, off of England, and they helped me very much. Chinese herbology, I mean, there's so many things that they're doing with animals and plants that as far as I'm concerned, God made and has healing. They have healing qualities, and they've studied this, and we need to learn. We have a lot more to learn. Yoga, I don't do yoga, but many people have said that helps them as well. So more power to you. Faith, healing, and prayer, like Shannon said in her talk. Boy, if you weren't a prayer warrior before, you might become a prayer warrior, because that's just about all you can think about is God, help me. God, save me. God, am I going to make it through today? I read a book about communion. In the Christian religion, we believe that when Jesus was crucified, he bore our sins and our infirmities. And so these are promises that we can claim, and we can believe that God loves us and God wants us to be healed. And so last year I was taking communion every day, and that was helping me as well. Dr. Caroline Leaf, if you've not heard of her, she's doing some really interesting work on the brain and actually neuroimaging of what negative thinking can do to the brain. She shows it's sort of like growing, it's sort of like having dead trees in your brain, and when you start thinking more positively, and that sounds a little shallow, but she goes at great length about how to retrain your brain to think positively and hopefully, and she then shows neuroimaging of how those dead-looking trees are replaced by very living looking things. And so she does interesting work too. I'll just give you that name. EHT is a supplement I started taking in September. You might have heard of it. It's fairly new. A lot of people are finding benefits from it, and I haven't stopped taking it. I mean, if something works, I'm not going to mess with it. So I started taking it in September. Cognitive behavioral therapy, super important. Wayne Gordon on the top right, and Theo Sadosis on the bottom right. I worked with Theo about 6 years ago at Mount Sinai Medical Center in New York. Very helpful, very helpful. It's the sort of things you can share with your survivor friends, like at a coffee shop, and on the back of an envelope, draw a model that will help them untangle certain things that are weighing them down. Extremely helpful for me. So this is kind of the woulda, coulda, shoulda. Next, this is in the psychiatry realm. Some of the most helpful therapy is that was then, this is now. That was then, this is now. That was your life, yes, but this is your new life. Make the most of it. And of course, who doesn't enjoy looking at a picture of a little baby pig? I mean, I'm not above that. I look at pictures of puppies and kittens, and it helps. So again, just to recap, your brain injury is as specific as your fingerprint, and so should be your course of treatments. Try them all. You owe it to yourself to create the multi-tooth key to your recovery. And I'll pause here and go to acceptance. That's the final stretch. Any questions before I move on to the end?
Yeah, I have a question, John. I want you to, it's not so much a question, but I want you to expand on your support group meetings in Wichita. Tell them about that. What you've learned,
Well, Shannon has introduced me to a support group meeting in Wichita that meets twice a month, and I've met some incredible people who experience brain injuries from all kinds of ways. Heroin overdose. There was a woman who was 6 years old. She was about 40 now, but when she was 6, she was crossing the street, and a car hit her because it ran a light. And it not only hit her, she was hit about 100 feet in the air, and the car hit her a second time on her way down. Well, here she is in the support group after being in a coma as a child. And so these support groups, Shannon, I think, one of the things that are so very helpful to those of us who attend is learning strategies from each other, and even just the physical presence of being in the same room, making eye contact with them, and basically saying, I'm here for you. How can I help?
Oh, yeah.
And we see that. We see people who themselves are survivors, but they've been in it longer. You've been injured since 1984.
Yeah.
1984. So you bring a lot to the table at support group meetings. And people look at you and say, look at her. She's got a radio show. She's doing all these things, and the doctors were telling your parents that you weren't going to live.
Oh, no.
And if you did come out of the coma, you wouldn't talk again, you wouldn't walk again. Not only are you talking, you've got a radio show.
Yeah, and John, you were mentioning how depression, about you were depressed after the accident and all that. Well, when I in high school, like after high school and all that, I was depressed. I couldn't get a job. No one would hire me. I wasn't fast enough to run a cashier. I'd be a grocery store cashier. Wasn't quick enough on things and all that. And just the negativity that a person goes through. I told my mom, like, I would be, I'd make it easy for her. I'd put a dress on and I'd just lay down on the couch and I'd commit suicide, and
Mm-hmm.
just, and that, I was just so low,
Yeah. Yeah. Well, what helped you, Shannon? What did you do? What was your go-to strategies for feeling less depressed?
Well, the positive aspect of my mom, just her encouraging me, and she would say, well, Shannon, you could still be there laying in that bed, but no, you got, you learn to walk again and all that.
Mm-hmm.
So, it's a lot of it has to do with your family, your teamwork, the care team, not only doctors but family members.
Yeah.
And I remember my mom in my physical in my rehab. Um, they would meet like oh, every 3 weeks and all that. My occupational physical speech uh, and my doctor, would my hospitalist doctor would come
Hmm.
and they would just review my case,
Uh-huh.
and
Yeah.
all that.
Yeah.
So, but um, a person has to be, um, you have to be positive,
Hmm.
um, because, and I'm afraid that there aren't many people, out there that are given the situation that a TBI or brain injury, in the hospital, you know.
Well, let me take an opportunity just to jump in here, and I'm sorry,
Mhm.
we're gonna have to wrap it up. I have another hangout, but I hope this is just the beginning because, like you've all alluded to, it helps to have support, and that recovery from brain injury is more than physical; it's a lot mental, and the team approach seems like a very valid approach. But I hope John and Shannon and the new arrival can use this platform of Hangouts to do exactly what we're doing right now,
Hmm.
talking, talking, talking about the team approach, talking about support, talking about the way the things that work for you. This is a wonderful platform. Before we close, Victor, do you have something to say to John and the group? Victor,
Excuse me?
do you have anything to
Yeah,
say to John and the group before we
yes.
close? I've got to go. But
No, only to say him that I want to felicitate him, to congratulate with with his conference. It was really good, really nice, because there is not only the scientific um, mind, also some other things like the sensitive kind of the brain. So congratulations.
Thank you.
and our new arrival, I'm sorry I forgot your name. Could you have any closing remarks?
I appreciate that you all are doing this. And I would love, I have my stake in the ground for a new worker cooperative. And so I would love to visit about all the ways that we can use technology. The HIPAA compliant form I think is very important though, so I'm not sure how we can legally be using Google Hangout, which is very discoverable.
Okay.
The Cisco WebEx system is a webinar system. It has 100 polling chats on it.
Okay.
So we can use the Native American talking circles. I have a website, so I'd love to visit more about how we make use of these opportunities that have been gifted to me over the years. And to this point in time where we have science and technology and spirituality coming together, where we really need to heal the world from all the traumas that we have from all the wars, all the ways that we have dementia, and now they're saying we can prevent dementia if we catch it soon enough. So just like I was an old cardiac rehab nurse, so physical therapy is really play therapy, and that isn't covered under a PT guideline. So I'm in the Association of Applied and Therapeutic Humor. There's many interdisciplinary things, but they're not connected. Everybody doesn't see how to put this new system together. So I believe that we have to work on the new system, that we have to have collaborative meetings, and I would invite you, Dr. Bennett, that knows the people in the neurological circles. How do we do this? And then John Byler just left my house last night. And Shannon just got us together. Now there is a gal out in San Diego that is a researcher, comes from a very interesting background. So I believe that we have to have some actual HIPAA compliant meetings, and I
Okay.
would be
Okay.
willing to host those.
Okay. We'll deal with that. But this is just the first step to show you this platform. John knows about it, but it's certainly usable by anybody for support, whether it be medical education or patient support. It's just a great tool. I found it as a great tool to get people together. And I thank you all for coming tonight. And thank you, John, for another excellent presentation.
Congratulations, John, for pulling everybody together all
Yeah.
over the world.
Well,
It's amazing what you've
John,
done.
this is a great tool. I hope to help you use it.
I'm looking
And
forward
you
to it.
know,
También mucho
part of
gusto,
neurosurgical TV,
Victor.
John, part of neurosurgical TV is going to be brain trauma support. So we'd love to make a channel for you there.
Okay, you're
Oh,
on.
that'd be awesome.
Yeah, we'd love to do it. So Shannon, push John to get that
Okay.
channel together. Okay,
Alrighty.
Okay.
my new arrival has just come for our next talk.
Okay.
And,
Thanks so much.
okay,
Okay,
thank
I'm
you.
gonna sign off.
Thank you.
Bye.
Yeah. Bye bye.
Okay, Victor, this is a neurosurgeon. I'd like you to meet her. Thank you, Shannon. Okay,
Yes, sir.
let me. This is Anila. Hello,
Hello,
Anila.
how are you?
How you
Hi, how are
doing?
you, John?
Thank you for coming.
Good. Thank you. I got my internet figured out at last.
Oh, good, Anila. I think you have to brighten your room up a little bit. You're looking very dark.
Okay, all right.
You have any light there?
I think all the lights are on.
Really?
Maybe I just have to sit somewhere else.
Well, it's not really that important. It's okay, but is there any easy way you can do it?
Yeah, I'll just move from this part to somewhere else. See if you
just
can
turn
see me
the
better.
desk around. There you go. You look a lot better. Yeah, that's better.
Yeah, that's better. Okay.
Yeah, that's better. Okay, let me just get hold on here. Let me just get things together. Let me introduce you to some people. Well, I guess you'll meet during introductions. Hold on. Neela Darbar.
John, my battery is dying. Hold on, I didn't even see that. I think I have to go get my charger. I'll be back in 1 second.
Yeah, no problem.
Okay.
Okay.
Hey, John, how do I get out of this?
Okay.
Tab under Google Hangouts if you want to leave.
Oh, okay.
Oh. See you later, John. Thank you so much.
Okay, Shannon, thank you.
Bye-bye. Bye, Helen. Bye, Doctor.
Bye.
From Mexico.
Yeah.
Okay. Yes. Bye-bye.
Bye.
John, I'm not sure if you want me to stay or how this is since I
Well,
am.
it's kind of it's science. I don't know if you'd like it. It's
Okay.
Neurosurgery, but certainly please get John to form a support group and hangouts, and I think you guys could really benefit by it. And I'll be glad to set it up.
Okay. How does that work with patient privacy?
Well, it's as private as you want to make it. If you don't want to reveal things, you don't reveal them.
But it's still discoverable by everybody is what I'm saying. So.
Well, we'll talk about that later, okay?
Okay, very good. Thank you.
Thank you.
Okay, I'm back. John, I'm back.
Okay, an endoscopic skull base approaches.
Yeah.
Okay. I know. I tell you, Anila, this is the last one of 24 presentations.
Not a lot, many people will be watching it, but that's all right.
I may be a little squirrely,
Yeah.
but yeah, endoscopic skull base. You know, Victor, I wish I knew this. I know I appreciate you coming in at the last moment, Anila, but we have
Yeah.
a
No
Mexican
worries.
neurosurgeon, Dr. Eduardo Flores. Do you know him, Victor?
Yeah.
Yeah, he's a big endoscopic guy. I wish he was. He would love to have heard you, but he'll see your video. He'll see it, and we'll get the
Yeah.
community going. So we'll have an endoscopy channel maybe. So okay, let me. I'm going to start this formally because this is going to be edited out and it's just going to be formal. So let me start in a second. Okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening. This is Dr. John Bennett. Today we have uh, the good fortune of having Anila Darbar, excuse me, MD. She's a neurosurgeon that from Pakistan originally. She worked in St. Louis and now she's back in Pakistan. She's going to talk about endoscopic skull base approaches. And also we have a very distinguished member of the panel, Victor Hugo Perez, who did a fantastic impromptu discussion today of neuroanatomy. First, we'll greet Victor. Hi, Victor.
Hi, how are you?
How you going, Victor? Can you talk a little bit about yourself, please?
Yeah, it's very nice to know you. And yeah, of course, Mexico City. So I have been
Where do you
doing.
practice, Victor? Where do you practice?
My practice is in Centro Médico Nacional. I am a skull-based surgeon and also spine surgeon. I did a research fellowship in Detroit, Michigan about 23 years ago. So right now I am doing a skull-based surgery and also research in anatomy, surgical anatomy of the brain, skull base, and also the spine.
Very good. Welcome, Victor. Okay, Lanila, it's your show.
All right, so let me just start this. I'm going to minimize this first.
Okay, can you just say a few words about yourself, Anila, where you went to school,
Sure.
residency?
I am sure. I am Anila Darbar, and I did my neurosurgical residency from State University of New York at Syracuse. And then I did my first fellowship in the endoscopic surgery with Dr. Charlie Teo in Sydney, Australia. And then I joined the St. Louis University. I did my second fellowship with Dr. Salim Abdul Rauf in vascular and skull base surgery. And then I was a faculty there for 3 years. And then I moved to Pakistan, which is my home country now. And I practice in a university called the Aga Khan University in Karachi.
Very good.
So I'm
Okay.
just going to start now.
Oh, sure.
First I have to open this.
Okay.
I am not seeing the button here at the
Okay.
edge of the task in the task bar. I am unable to see. I've opened my PowerPoint, but
Okay. Okay. Go to the taskbar and open the Hangout again. Click on the Hangout again. Come back into the Hangout and go to the
okay.
menu on the left side. Click on Screen Share. You got that?
Yeah, I got that. I did the
Okay.
screen share now.
Now, does it open up and show you a couple of options on what to pick?
both the options are, one is a hangout and the other one is entire screen.
Okay. First, exit the Hangout by the right hand corner. There's a minimize button. Exit the
I did.
Hangout. Okay,
I did.
now you got your screen, your desktop in front of you. Open up the
Correct.
PowerPoint. Open up the
Okay.
PowerPoint and leave it there.
Okay, I did it.
Okay, then now go to the taskbar and open the Hangout again. Okay, did you open the taskbar at the
Yeah.
bottom?
Yes. Yeah,
Okay,
I
now
did it.
go to the menu on the left. Go to the screen
Yeah.
share. Click the screen share button.
Okay.
Now
Yeah.
another screen should open, giving you options. Your screen share should be
Yeah.
there. Should be there.
Yeah. Do you see it?
Yeah, yes.
Okay.
Okay, click on the appropriate place to slide or whatever.
Yeah. So this is the first slide. Can you see the endoscopic skull base approaches?
Yes, you gotta click on the slide, I believe, to start it.
Is it working? Do you see it?
No, we're seeing a bunch of slides. We're not seeing the one slide. You want to show one slide, right?
Yeah. I have. Okay. So why is this happening?
There you go. Now click on each individual slide. There you go. Okay, there you got it. And now when you change slides, you have to go to the left column and click one by one.
Oh, okay. So I just can't run the slideshow. Okay,
Yeah,
I got
exactly.
it.
Okay, you're
Okay.
off. You're off.
I'm on. Okay. So I will be talking about the endoscopic skull base approaches. And this picture just shares what is the current status of the skull base surgery. And we can access the most common use of the endoscopic surgery. Most of the neurosurgeons around the world use it for accessing the sella, and most of the transsphenoidal surgery these days are actually done endoscopically. But along with the sella, you can also access via the endoscope the anterior skull base, and also you can access it the posterior skull base all the way up to the clivus. The advantages of using the endoscopic skull base is that it has more rapid access, it gives you brighter illumination and visualization, it gives you greater magnification, a wider field of view, and then you can directly inspect the tumor bed. The other advantages are that you do not require any kind of nasal packing or nasal splints as when you use in microscope. There is also less post-operative discomfort, and also eliminates most of the other ENT complications that used to have in the older kind of procedure, which was done before the endoscopic procedure had gone into vogue. There is definitely better degree of tumor resection, especially now. There are safer surgical corridors that you can use. There are lesser complications and definitely much more shorter recovery stay. Now, the advantages of endoscopic approach versus all the other approaches is that rapid access, the neurovascular hurdles doesn't come in your way, except if you are going into the anterior skull base or a little bit in the posterior skull base. It may or it may not, depending. The access to the midline tumors are great. Paramedian tumors, you have to think how much is the lateral access. If there is too much lateral access, that you won't be able to do it endoscopically. Some lateral access can be approached, but extremely lateral tumors, as I will show in my further slides, cannot be accessed through endoscopic surgery. You cannot do an en bloc resection, and the cosmesis is great because there are no cuts. Is all done through the nasal approach. Disadvantages: there are two-dimensional vision. Although there is a scope out there made by the Vision Sense these days, which gives you a 3D view, and you can wear one of those 3D goggles and have a view, and it gives you a good 3D approach. But in my experience of using that camera, I have found that the resolution is not fantastic, although the 3D approach is really good and the depth perception is good, but the what in my experience the resolution is not good. So I still use the traditional high resolution camera with the high resolution HD camera with the screen, which is usually made by any other company. I use Stores, but there are many other companies that make it. One of the other disadvantages is that a limited surgical corridor. Uh, Now, people who don't use endoscopes have a bigger view of the fogging and obscuration of the endoscope with blood, and it is a steep learning curve for you to understand how to get rid of it. I usually use a sheath with my endoscope with a direct irrigation that with a foot pedal. So whenever there is fogging or obscuring, I don't have to take my endoscope out. I just push the pedal and it irrigates my scope, and as a result of which my vision gets cleared, and that's why there is no delay in the surgical time by coming in and getting off. These things are very commonly available with any of the endoscopes if you go out in market and search for it. People who don't use endoscope, for them it's an unfamiliar anatomy, and that needs to be learned before going through it. And although in older days it was a one-handed surgeon technique, but now currently we use a four-handed surgeon technique actually. So we use both the nares, and through one nair the surgeon holds two instruments, and the assistant actually holds one suction and endoscope, as a result of which it is now a four-handed surgery, so much more easier, and as a result of it you can take bigger tumors out, anterior skull base tumors out, because they are four hands, just like if you're doing a regular surgery. The limitations are usually by location. So if your tumor is a lot into the cavernous sinus, especially if you're doing a sella or a suprasellar lesion, then there's a lot of cavernous sinus extension, then you are limited by taking the entire tumor off, in spite of using different degree scopes. And the other problem is that you cannot go caudal to C2, because no matter, even if you do a 70-degree scope, you won't be able to see so posterior inferiorly. Vascular tumors are very difficult to take out, and again the reason is because it fogs the scope so much that even a little bit of blood looks like a whole lot of blood when you're looking into the screen. And tumors that require en-bloc resection cannot be done through endoscope. There are some specific contraindications, like craniopharyngioma that has been resected several times before. Like a first-time craniopharyngioma in the sella and suprasellar can be accessed through endoscope, but if it is a redo procedure, then you have to be very careful, because sometimes these tumors are stuck to big vessels, they're stuck to carotids, they're stuck to the basilar. Sometimes the bone, the dorsum sella is actually not there because the tumor has eroded through it. So you have to be very careful in doing a redo craniopharyngioma or a redo meningioma through the endoscope. You just have to be very careful, maybe have your neuronavigation with you so that you can see where you are, or maybe do an open procedure in case you feel that the tumor would be stuck to the vessels. So for the anterior cranial fossa approach, anteriorly you usually have no limits. Laterally you have the optic nerves as seen over here, and that usually would limit you. And posteriorly there is no limit because you enter into the tuberculum sella and the sellar region then. So from here to here you can do a transplanum, transtuberculum, transcribriform approach. It's great for idiopathic as well as traumatic CSF leaks. You can easily put your scope, usually most of the leaks are through the cribriform plate. You can find the leak and then seal it. Of course, there are several ways of sealing it, which I'll divulge into it as my presentation goes on. It's rapid and relatively risk-free, and again, you're laterally bounded by the optic nerves and posteriorly by the circular sinus. But anything in this area Like for example, a tuberculum cellular meningioma is very easily accessible. If you even have an olfactory groove, that is also quite accessible through here, because the only thing you have to do here is actually just remove these bone and you would be just directly accessing the tumor. I usually use my ENT surgeon, who actually helps me drill the bone, even for this in all approaches, anterior, sella, posterior approaches. I use the ENT surgeon to do this approach, and then I go and do the tumor bit after. This is just some of the example of endonasal removal of the tumors. Unfortunately, my slideshow would have shown, because this is an animated picture, the slideshow would have seen the post-operative picture, but unfortunately I can't now in this case. John, if I put into the slideshow, it won't come, right? Okay. So again, this is you can, as I told you, can take olfactory groove tumors out. You can take the tuberculum cella, and this is just a post-op picture of the pre-op picture that was shown right here. Okay. So when you do tumors like these, of course, there is you have removed a bunch of bone, you have opened the dura, there's a huge CSF leak, right? And these are not the kind of CSF leak that can be just sealed with a fat graft or artificial dura or any other material, because they are big CSF leaks. They are not smaller CSF leaks like the one we have in the cellular approaches. So for this, you need a vascularized septal flap. This is the vessels that supply this vascular flap. It's the inner mucosa. This is called a Haddad flap by an ENT surgeon called Haddad, and basically it starts from where when your sphenoid ostium is, that starts from there. Then you go all the way up, and then the other part is actually into the nasopharynx, and then you join it together to raise a flap. The flap actually looks like that. This is just, I've just taken it out to show it like that, but it is attached. The flap is attached over here, and the blood supply, the sphenopalatine artery right there, and that is the blood supply of this. So there is a pedicle there. So once, what you do is actually when you start, you make this flap and then put it into the nasopharynx. And once you are done with all the drilling and the CSF leak and the tumor resection, you take this flap off from your nasopharynx and then just flip it right over up here. And then you have to make sure that the shiny side of the mucosa is up, and then you can seal this with either Tacil or any kind of fibrin glue. I usually put Tacil first. You can put a little bit of bone first here, whatever bone you have removed from the nasal septal bone. You can put it a bit of there over here, or I sometimes use the bone from the middle turbinate. The middle turbinate also gives you a good bone to put it up there. And then you put the flap on top of it, then put the Tacil, and then you can put Surgicel and some gel foam on top of it, and it will seal very nicely. You actually do not need any lumbar drains to go with it, because this flap, since it has a pedicle attached to it, vascularizes very quickly and seals the hole very nicely. I think it's quite commonly used these days. So this is the Haddad flap. Now, as I said, when you do the anterior skull base, you have to make sure what is your relationship is to the optic nerve. And again, this is actually animated pictures, so unfortunately,
Okay.
can you see it?
Well,
You can't see now?
Yeah, we can't see the animation. Are they supposed to be animated now?
Yeah, you can't see it?
No, we can see it, but we can't see any animation.
Oh, okay, got it. I have to go back. Okay, so we won't be able to see it then. Okay.
Okay.
So basically what this picture is showing, that if you have an inferior medial tumor, yes, you can take it out via the endoscope, but if you have a superior lateral tumor, then you won't be able to take it out. Then you may have to do some other approach. You can do like a coronal blood flap, or you can do a supraorbital approach, or whichever approach you use to take it out. So this picture is just it actually goes through several steps just to see which approach was taken, but unfortunately I don't think so I would be able to do it here. And again, this is again the same picture of this one taken out. And this was for the other one. Unfortunately, can't see the approaches. So the vital structures that are encountered when you do a transtuberculum, transplanum approaches are all these. And usually if you are a first-time endoscopic surgeon, then of course you cannot start with the anterior skull base approach. You have to start with the simpler cellar suprasellar approach, and once you are comfortable with it, then you can actually come into the anterior skull base. The most common one, of course, that's been used worldwide by many neurosurgeons, in fact I would say most now, is the cellar and the suprasellar approaches. Again, anteriorly you have no limits because you can take this part of the bone off. Laterally, again, the internal carotid artery becomes your it's a sort of a lateral extension, because sometimes you have natural fenestrations into the cavernous sinus, and so you can actually go in and take some of the tumor out from them. But if you don't, then of course you cannot take the extension that goes into the cavernous sinus, which it can be. I actually, if I cannot see a fenestration to the cavernous sinus and I feel I cannot take the part of the tumor off, then I usually leave the cavernous sinus tumor behind, and then usually use a cyber knife or some other method to take this completely make sure that the disease is gone. There are some surgeons who actually do skeletonize the internal carotid artery and do take the tumor out from the cavernous sinus. I don't. Posteriorly, again, there's no limits as we'll go through it. So this is the transcellular approach. Usually to the cellar, suprasellar, and partly the cavernous sinus. And again, as I said, laterally the carotids are your limitation. So here, if you see the anatomy, you can see the ICA and the cellar part. Now, as I said, there are surgeons who actually go drill the skeletonize this ICA and take quite an extension of the tumor out. I don't, but there are other surgeons who do that. And again, this is just some simple anatomy. The bony anatomy must be completely understood before undergoing these procedures, in which you have to understand where the optic nerves are, where the sella is, where the ICA is, and again you see the lateral the optic carotid recesses, which actually helps you to identify where the optic nerve and the ICAs are. So size is usually not a limitation of a larger tumor like that. You know, it's all going into the sphenoid sinus. You know, you can easily take it out, no problem. That's just a post-op scan. The bigger problem is actually the lateral extension, as I talked to you about. If you have lateral extension, as you can see over here, sometimes you are unable to, you can take the center part out, but sometimes laterally you can't. In that case, you can use either a subtemporal approach or any other approach to take it out. Meningiomas, yes, you can take pituitary tumors, yes, you can, all kind of pituitary non-functioning type of lesions or functioning can be taken out through this approach. Craniopharyngiomas, usually the initial craniopharyngiomas that are cellar and suprasellar extension are the best one to take it out. And as I said, if you have a redo craniopharyngioma, please do look at the anatomy. Even get a CT angiogram done, make sure there is bone there, the vessels are not exposed, the tumor is not adhered, if you are trying to do an endoscopic resection. Meningiomas, again, first time, it's not that difficult, you just need to know your anatomy. But if it is a redo, then again, you have to be very, very careful. And again, the craniopharyngiomas. Now, if you have this kind of tumor, the excess, now again, this is actually an animated picture that exactly just shows you that how to now if this craniopharyngioma, as you can see that between the optic nerve and the pituitary gland there is an access corridor, so it can be taken out. But for example, if the optic nerve is situated somewhere else, then probably this may not be a better approach, or the pituitary gland is completely up here, this tumor is completely suprasellar, not extending into the sella, then you would be damaging the pituitary gland, so then it would not be a good access. Then you may want to do a subfrontal or a terional approach to take the suprasellar component of the tumor out. Now again, this is an animation that actually just shows you, which I can't see over here. And you can use a subtemporal approach, as I told you. So the vital structures are the cavernous sinus is the most important one, with both ICH, which limits it laterally. Now again, in this case, in my practice, since the cellar defect is not a big defect, and depends on whether you have a CSF leak or you don't have a CSF leak. If you don't have a CSF leak, which is generally the case in case you are doing a cellar tumor, then you do not have to make a vascular septal flap or the Haddad flap that we talked about before. In this case, you can just simply use the mucosal free graft, which you can obtain from the middle turbinate. The middle turbinate is actually good. It gives you both bone as well as the mucosal free graft, and then you can just put the bone and the graft and then some fibrin glue to seal and Surgicel just to seal it up. People also use fascia lata to seal it up. In countries where the artificial dura is, like in Pakistan, artificial dura is too expensive to use. I mean, it's cost almost as much as the entire surgical procedure. So we cannot afford to use artificial dura as the way I used to use in the US. So in this case, people can use fascia lata. And again, I don't use fascia lata. I just use the middle turbinate graft. You can actually take both the middle turbinates off with impunity without any much issue, and that also gives you a lot of space, and your four-handed surgery can be done quite smoothly through that approach. So I just use that. So this is just a picture to sort of explain that. Okay, so again, very few limitations to the cellar approach. You can do the intranasal is easy, the sphenoid sinus one is easy, the suprasellar extension is easy, cavernous sinus is partially easy. But if you have a middle cranial fossa extension or the lateral extension, then you won't be able to take it out through the endonasal approach. You can either leave that tumor behind and use a subtemporal approach or a terional approach to take it out, or you can, or you can use CyberKnife, either depending on the pathology. And relative contraindication, again, as I said, that if you had a previous surgery, please be careful while doing the redo. I mean, as far as redo pituitary is okay, but just redo any other kind of redos you have to be careful about. Next is the posterior cranial fossa. Now, posterior cranial fossa is probably the least that people do. In fact, in my practice, is also the very few indications to go to the posterior cranial fossa. So more indications are for the sella and the anterior lesion. Now, if you go to posteriorly, it's usually for if there is like if you're doing a biopsy or there is some extension of a chordoma or something like that you don't have to access it. You don't have to like open the dura to go on the other side. I mean, there are some neurosurgeons who actually does take the entire clivus out, does open the dura to access the midbrain, the brainstem through this area. I don't in my practice. It's only for me in case there is a clival chordoma which has an extension that I can take it out for a biopsy, or much more simpler cases that I do it for. This is now the transclival approach. Again, the most important thing is the carotid at this level is actually quite far apart. So, like in the cavernous sinus, as you know that how the carotids are very laterally at the more posterior part of the sella, and then it sort of comes around at the more superior part. So the same way here, in the transclavial approach, the carotids are actually quite laterally, so you don't have to worry about. Once you drill the bone, what will you will access the dura, and there's a lot of venous plexus around this area. So you may have some bleed from that. But again, in my practice, I only use this in case there is some sort of a clival lesion that I need to biopsy or a smaller lesion that I can access. This is just a little bit of the anatomy of this area. When you go through this area, I'm not going to go into detail of that. Everybody knows the anatomy. So this is one example of a petrous cholesterol granuloma that could be accessed through this area, but just for since it was a smaller lesion, it was easy. This was an extradural intradural chordoma. I only took the extradural part out of it through here. And the structures that are important is the basal and vertebral artery, but that comes after the dura. If you don't open the dura, if you just remove the bone to remove the extradural lesion, then you don't even have to access this area. But these are the vital structure around this area, and as I said, there are surgeons who would actually expose the entire clivus and would open the dura to reach the brainstem through these areas. Again, this is not my practice. So this is the conclusion that, again, a well-trained skull-based neurosurgeon needs to be familiar with both the transcranial and endonasal approaches, because endonasal does have limitation. As I said, that the midline lesions can be accessed, but anything that's lateral is not that easy to access, and that has to be done either transcranial approach or through radiation. And the best approach, you have to really tailor the approach according to the patient after carefully looking at the scans, and the best one is that avoids the neurovascular structure and gives you the best oncological, neurosurgical, and cosmetic results. Thank you so much.
Well, thank you very much, Anila. And I tell you, I'm very glad that you came in at the last minute. I know you must be hungry for knowledge, and you must be hungry for new technology.
Yes.
And I love your attitude. I love your attitude of wanting to try things, which is the attitude that probably made you a really good neurosurgeon, I'm sure. And we're very lucky to have Victor here because Victor is a skull-based neurosurgeon too. Victor, would you like to make any comments or questions to Anila?
Yeah, I have some questions, especially in the presellar and sellar region. Have you operated malignant tumors, like esthesioneuroblastomas? Because some small meningiomas could be operated your technique, but some malignant tumors, what is the prognostic in these kind of tumors?
So I have not operated on any kind of neuroasthenioblastomas. I have operated on a couple of metastatic lesions that were actually in the sort of suprasellar area that could have been accessed through the endoscope. But as I said, I have not had the experience to do. The only malignant tumor I have done through the sella is the metastatic lesion. Then I have also had a chance to do a glioblastoma that was actually accessing, it was in the third ventricle. I just recently did that in a 21-year-old girl. It was a GBM which was in the sella and the suprasellar region, and I had to access it from the ventricle. So I actually access it from the top through the foramen of Monroe into the third ventricle. I partially resected the suprasellar component through that, and then I went endoscopically into the sellar area and removed the rest of it from that area. So these are my two experiences with the malignant lesions.
Could you please get off the screen share, Anila, so we can talk to you? We're just looking at the screen. Yeah, just click on.
Sorry.
Yeah, it's okay. Click on the green arrow and take it off it.
Okay.
Just click on that green arrow
Okay.
on the there you go. Okay, there you go.
Okay.
There you go. Okay, any more questions, Victor?
Yeah. Okay, Dr. Anila, another question is how many cerebrospinal fluids leakage do you have had in this kind of procedures?
So with the vascular septal flap, since I have started like in my residency, we did not used to use the vascular septal flap. So when I was training during during my residency, but once when I did my fellowship, then I started to use that septal flap, the Haddad flap with the vascular pedicle, and that has significantly reduced the CSF leak. So, I mean, it is not more than 5 to 7%. I mean, it's rarely you would see CSF leak these days now with the septal
Okay,
flap. And you don't even need a
okay,
lumbar drain. You don't even have to put a lumbar drain. Without the lumbar drain, just the septal flap, it works out fine.
okay. Another question is which has been the most difficult tumor, kind of tumor to operate by this kind of technique, by endoscopic technique for your experience?
So the cellar, paracellar are great. Craniopharyngiomas, initial craniopharyngiomas are also very easy to take out. Meningiomas
Okay,
can be difficult because they are harder tumors. And for that you need so there's a specific kind of instrument that's out available which actually vibrates like a Pac-Man. And it vibrates. It's not CUSA. It is a different instrument, and if you have that, then actually taking meningiomas out is much more easier. It is, as I said, ultrasonic instrument, and it just cuts the tumor like that. It's like have you seen a mucosal debrider that an ENT person uses? Have you seen that? Do you know what a mucosal debrider is that an ENT surgeon uses? It is just a tinier version of a mucosal debrider, and for meningioma, since they are hard, that's easier to take out through that.
okay.
Okay.
Okay, congratulations for your successful procedures in this very difficult resection of tumors, because when we don't have that technology, we have to use a very wide procedures, very big procedures on the skull base. And if we have a good technology like you to use an endoscope, and also the experience is much better for the patient. Really, congratulations for your technique.
Thank you so much, Dr. Victor. Thank you so much.
Very good, Anil. Well, I hope you become part of our team where you attend these regularly, and you're welcome. You're welcome to see them. Victor did a great one this morning. He's a neuroanatomist, and
Uh-huh.
he makes
I
some.
would love to. I would
Yeah,
love to see Victor's videos. Yes.
yeah, I'm going to show you Victor's video he made this morning. Just an awesome. I mean, the other neurosurgeons were awestruck. There was a wow because he had a live filling of the vessels. And he was describing the anatomy as. How would you describe that, Victor, to Anita? What you were doing this morning?
Well, excuse me again.
How would
Again.
you describe the videos you were showing us this morning, Ipe and I, and Dr. Herrera? You don't remember
So,
those videos you were showing us this morning?
okay, do you have time in order to show you some video about this region?
Okay, well, sure. If Neil has a second, you have a second on Neil?
Yeah. 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 I do.
Okay, yes. I think she'd enjoy it.
Okay, only two minutes.
Yeah, sure.
Thank 2 minutes.
Okay.
Okay.
Do a screen share now, Victor. Can you screen share or? Oh, there you go. There you go. You got it. You see that, Neela?
Yeah, I'm seeing it.
Okay. Could you show the one that
Um,
was live
the
where the vessels are filling?
the the Willis circle. What we are seeing now is a supraclinal segment of both carotid arteries.
Uh-huh.
Um, you know, as you have said, Dr. Anela, when we try to remove some tumors in the suprasellar region, we must know the arteries that are surrounded that kind of tumors. In here, I am explaining the arteries, the small arteries. This is the posterior communicating artery.
Mm-hmm.
Let me show you another video. I think is very important in order to see the anterior communicating arteries and also the arteries that are coming from the anterior communicating artery. This is the anterior cerebral artery, the other one, and this is the communicating anterior artery. The two segments of the anterior arteries, anterior cerebral arteries, and this is the A1 segment of the anterior cerebral arteries, and in okay okay, much better in this. I am going to displace the frontal lobe, and you are seeing in this of Hübner, recurrent artery of Hübner, and the arrow in here is showing the small arteries that are coming from the anterior communicating artery. Here, in this side, is the origin of the recurrent artery of Hübner, this, and the small arteries that are coming from this segment of this artery. I have almost 100 brains injected with silicone in order to see these arteries and its branches and their branches.
Wow, it's fantastic work, Victor.
Excuse me?
Fantastic work.
Well, I'm gonna send you his video, Anila, that he made this
Okay.
morning. It's a long. You'll be. I think if you love it, most neurosurgeons I've met love anatomy. Uh,
Yeah.
so I'm sure you're one of them, and I'm sure
Yeah.
you'll love his video. And Victor's going to be a part of this whole channel. So
Great.
okay, Anila, I'll let you go. I know this is probably your day off. I really appreciate you coming by and your time off to
No
help me.
worries. I enjoyed it. Thank you very much for inviting me. I really enjoyed doing it.
Well,
Uh,
I
look,
hope you have
look,
hangouts like that to educate the world, not just a few people. Once we get going, I hope we get a pretty big audience
look,
worldwide, not just in Pakistan, but in the
uh,
world.
Dr. John,
Yes.
Dr. Anila,
Yes.
look at this picture.
Okay.
In here we are seeing the optic nerves, this and the other one, the optic chiasma and the
Mhm.
carotid supraclinode. and this is really nice because in here we can see with a very specific detail the small branches of these arteries.
That's important to know. Huh?
I hope to, yeah, I hope to participate in the next courses with John Bennett in order to show you this kind of work.
Yeah, our next conference, Anila, is skull-based surgery. Probably
Okay.
in a couple of weeks, and you're welcome to present if you'd like to present at the skull-based surgery.
Sure. Great. Yeah, I would love to.
Great. Okay, Victor.
Okay.
Okay.
Thank you
Yeah.
both very much.
Thank you.
Okay, good night.
Good night.
Bye bye.